Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about sickle cell disease with Dr. Cece Calhoun. Dr. Calhoun is an assistant professor of medicine in hematology at the Yale School of Medicine. Here's Dr. Weiner.
I usually start off just asking people a little bit about themselves, and maybe you could just tell us where you grew up and where you've been and how it is that you became interested in sickle cell disease in particular.
Absolutely. So I usually start off with my title, but since you asked me where I grew up, I'm from Detroit, Michigan. I'm a Midwest girl, born and raised, and had the pleasure of doing my medical school training in Detroit, where I'm from, in my community that raised me and really supported me in my own medical journey. It was during my time in med school that I had, I would say, my first meaningful exposure to a patient with sickle cell disease. And it, for me, represented the nexus of so many things I like. It was the science. It was hematology. I love the red blood cell. It was children and young adults with sickle cell and the disease itself and giving to my community. And so it was there that I was like, this is a career path I want to pursue. I want to be a hematologist. And I am a lifespan hematologist here at Yale.
Wow, that's great. And actually, you're trained as a pediatrician, are you not?
Yes, I am.
Although, and I know you still do a little pediatrics, but you also very much focus on adults with sickle cell disease. Do you mind just starting off explaining to our listeners what sickle cell disease is, how is it that it occurs?
Yeah, absolutely. I'll do my best to be brief because it's something I'm really excited about. But
it's okay. This is one where I think we need the full explanation.
Okay, sounds good.
Including the malaria connection.
Okay. Sounds good. So sickle cell disease is a disease of our red blood cell, which, as you know, transports oxygen around our body, helping to keep all of our tissues healthy and safe. Normally, a red blood cell looks like what I describe as a jelly donut. The technical term, it's a biconcave disc. But when you have sickle cell, you are born with, so you inherited a genetic change in which instead of your red blood cells being shaped like a jelly donut, they're shaped more like a crescent, banana, or a sickle, which is why it's called sickle cell. In addition to being shaped differently, they're also quite sticky and quite brittle. And so if we think about our blood vessels as pipes, those jelly donut cells are carrying oxygen around, very squishy, bouncing off the sides of the wall, delivering oxygen to where it needs to go. But if you replace upwards of 95% of those cells with sickled cells that are shaped differently, that are brittle, that are sticky, you can imagine maybe they're injuring the sides of those blood vessels or sticking to each other, or maybe sticking to the sides of the blood vessel wall. And it is that inflammatory process, that inflammation from damage. It is that sticking together and preventing the flow of blood to other parts of our body that really is behind the physiology or pathophysiology of sickle cell.
And if I can just jump in for a sec, this all happens because of the substitution of a single amino acid. Is that correct?
That's 100% correct. And we found out about this in the early 1900s. Sickle cell was described. Just this one small genetic change has so many implications for every organ in our body.
But that small genetic change leads to the gene not functioning normally.
Absolutely. And so you might say to yourself, well, why do we have this? You know, if this is something that's bad, why does sickle cell disease, why is it pervasive? Why is it the most common monogenic disorder in the world? And so you kind of alluded to this a bit earlier in that we believe that sickle cell trait is protective against malaria. So malaria is a little kind of protozoa that finds a home in our red blood cells. It really thrives there in a normal red blood cell. But if that cell is shaped differently, or if the oxygen is lower, then it can't live there. So sickle cell trait is protective against malaria, and which is why it has continued to persist worldwide.
And do you want to just tell us for a second the difference between sickle cell trait and sickle cell anemia?
Yeah, absolutely. So, like many things in life, we get some from our mom and some from our dad. And so sickle cell disease is autosomal recessive, meaning that in order for you to have the physical manifestation of the disease, you need to have one part of sickle cell from your mom and one part of sickle cell from your dad. So those parents can be sickle cell carriers or carry the trait and not have any overt manifestations of sickle cell disease, but sickle cell anemia is when you have both copies and have fully displayed disease.
But so having the trait is enough in and of itself to be protective against malaria.
Yes, that is why it has persisted. And when we think about the mechanisms behind that, there are a few different theories. I think the most common theory is around that cell being completely shaped differently. But the other thing I mentioned earlier was the oxygen environment that's not conducive to replication for that malaria parasite. So that is the kind of second thing, if we want to get really nerdy about it.
Yeah, no. It's good. And, in a climate where there was a lot of malaria, that is in Africa, then in fact, it makes sense that people with sickle cell trait would have an advantage. They would survive their malaria. They would go on and have children. And some of those children, or theoretically 1 in 4 of children from that arise from two people who have trait, would have sickle cell disease.
Yes, and we find that worldwide, again, sickle cell disease is still the most common monogenic blood disorder, because it's not just Africa, but also India, parts of Arab America, Mediterranean, where sickle cell disease persists. And so we estimate that there are about 360,000 new births worldwide each year. So it continues to remain super prevalent, and the incidence is also increasing.
So before we talk about some of the complications from sickle cell anemia, maybe we can take another step down that sort of nerdy pathway as you described it, and you could just explain to the audience why sometimes in very young children, that is after they're born, that sickle cell disease isn't really much of a problem at first, because there's still something else around that helps them.
So I do want to say, I believe that being a nerd is very cool. Obviously, I have a bias. But just to answer your question, absolutely. And I think we'll revisit this concept as we move further along in our conversation. But, as we talked about, sickle cell is inherited. And so, as you mentioned, infants are born with sickle cell. But when they're younger, the physical manifestations are not as prominent. And it's not just because children are resilient and their regenerative capacity of youth is greater, but it's also because of the presence of fetal hemoglobin, meaning the hemoglobin that we make when we're a baby. These cells are even larger. I describe them to my patients as really fat, juicy cells that hold on to oxygen quite well and really mitigate a lot of the clinical symptoms of sickle cell. When we think about the persistence into adulthood, so people with sickle cell disease who have more fetal hemoglobin tend to do better. And certainly as we think about our disease-modifying therapies and curative therapies, really increasing that fetal hemoglobin is something we target.
Wow. So let's talk a little bit about what happens when all those sticky cells clog up all the blood vessels. And maybe you could talk about both some of the common symptoms that people have first, and then we'll get into some of the sort of organ damage and complications that can arise.
Absolutely. So the hallmark of sickle cell disease clinically is pain. I believe that when most people, if you have a personal connection to someone with sickle cell disease, then you think about unpredictable, severe, debilitating pain that affects their quality of life. that has a lot to do with the lack of that oxygen blood flow, but also that return of oxygen. Like if your arm has ever fallen asleep and then the circulation comes back. But that pain is severe and often equated to something like a long bone fracture, and can be very disruptive. But because sickle cell disease is a disease of the red blood cell, that means everywhere that blood goes, sickle cells can impact. And so when we think about other types of organ damage, we screen for eye damage like retinopathy. We think about the kidneys and making sure the kidneys are okay. Here at Yale, one of our trainees is really looking at the impact of neurologic complications, both subclinical and overtly, most notably stroke, which is what we have a lot of data and information about in sickle cell disease, but people don't talk about. Sickle cell disease affects every part of the body.
And typically when people are diagnosed, are they diagnosed as young children?
So here in the U.S., due to the collaboration of many centers across the United States and tremendous advocacy efforts, children with sickle cell disease born in the U.S. are diagnosed on a newborn screen test. So many of the audience may remember they have a kid and maybe they'll do a heel prick and get a drop of blood, and it tests for many inherited genetic disorders, and one of those is sickle cell. And what that has allowed us to do is detect sickle cell early and intervene early, because though children may not have a lot of pain because of that fetal hemoglobin and protection, they're still quite susceptible to really, really severe infections that could be fatal. And we diagnose them and we start penicillin prophylactically to really protect them and give them the best chance of thriving into adulthood.
And how long does that fetal hemoglobin typically stick around? I mean, you mentioned that there are some people who have persistence of fetal hemoglobin who, even into adulthood, who may have a more mild case, but typically it doesn't stay around all that long, isn't that?
No. In people who don't have sickle cell disease, the hemoglobin begins to transition from the mom to the baby as soon as 6 to 8 weeks after birth. And people who have conditions of the red blood cell, that fetal hemoglobin can try to persist on its own, but it really doesn't last outside of the tolerant infancy period, except for those rare instances where patients have a genetic predisposition to keep that fetal hemoglobin. Again, evolution is really a really cool thing. Love science. Humans are amazing. But most people, it's gone when they're, it is gone by the time they're into their even school age.
Got it. And the fetal hemoglobin, I mean, you mentioned transitioning from maternal hemoglobin to the hemoglobin of the child, but is that fetal hemoglobin in some way related to maternal hemoglobin?
So, it switches. So, we make all of the cells in our blood. Our warehouse is our bone marrow. But when we're inside of our mother, she's supporting us through the placenta. And so as we start to ramp up our own production, again, science is cool. Humans are amazing. We recognize, hey, I have the capacity to make my own red blood cells. And our reliance on those cells that were present from our mother are no longer necessary.
And so that first hemoglobin is the fetal hemoglobin that's made?
So I always tell my patients F for fetal hemoglobin, because that's what they're making when they're inside mom. But it takes over and becomes more predominant once we're outside of the body.
Got it. Well, we're going to have to take a break now, but I'm sure everyone's going to be back because you're so engaging. And we'll be back in just a minute to continue our conversation with Cece Calhoun, the director of the Sickle Cell Program at Yale.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, offering spiritual care to patients and caregivers seeking peace in the midst of their cancer journey, while respecting the philosophies, spiritualities, and religions of patients and caregivers. SmiloCancerHospital.org. The American Cancer Society estimates that more than 65,000 Americans will be diagnosed with head and neck cancer this year, making up about 4% of all cancers diagnosed. When detected early, however, head and neck cancers are easily treated and highly curable. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for head and neck cancers. Yale Cancer Center was recently awarded grants from the National Institutes of Health to fund the Yale Head and Neck Cancer Specialized Program of Research Excellence, or SPORE, to address critical barriers to treatment of head and neck squamous cell carcinoma due to resistance to immune, DNA damaging, and targeted therapy. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Hello, this is Eric Weiner again, welcoming you back to the second half of our show tonight. This is Yale Cancer Answers, and we're speaking with Dr. Cece Calhoun, director of the Sickle Cell Program at Yale. So we've been talking a lot about sickle cell disease and some of the manifestations. We haven't yet touched on treatments, and maybe we can begin talking about treatments and what's available today for people who are struggling to live the best life they can with sickle cell disease.
Yes, this is a interesting question, a complicated question. So we talked a little bit earlier about how we've known about sickle cell disease and its manifestations for over about 120 years. But really up until about 1998, we had where the FDA approved hydroxyurea for the treatment of sickle cell disease. There were really no disease-modifying medications. We used blood because it is a disease of the red blood cell, but had no interventions to treat actual sickle cell. In 1998, hydroxyurea was FDA approved, and then there was about a 20-year gap until additional treatments were introduced. Then we got Indari, which is an amino acid powder that's taken 3 times a day, really thought to help with that environment in which cells sickle and prevent that. Then we were able to FDA approved crizanlizumab, which is a type of infusion medication, which tries to make that environment less sticky. We talked about how those sickle cells are sticky. They stick together. They block flow. Also, a medication called Oxbryta was introduced, which binds to that spot where oxygen would sit in the red blood cell to prevent sickling. But about 4 weeks ago, that medication was abruptly discontinued. And so these are options to treat sickle cell disease that we have now. Now you're saying, Cece, but I heard about gene therapy. What do you mean? I thought that was for sickle cell. I'm picking up on the vibes, okay? And even before gene therapy, we did have one curative option, which is bone marrow transplant. We talked about earlier that the factory for our red blood cells, our white blood cells, and our platelets is our bone marrow. And so if you replace someone who has sickle cell disease, if you replace their bone marrow with the marrow of someone who doesn't have sickle cell disease, who maybe even only has trait, then you can cure the disease. But that's very complicated.
It's a harsh treatment too.
Absolutely.
And there's some number of people who don't make it through that treatment.
Mm-hmm. And there are many reasons for that, not least of which being it's important to have a perfect match. We want to have a perfect match for someone undergoing bone marrow transplant. And due to the genetic diversity in us all, again, we get half of that needed match from our mom, half of that needed match from our dad. The best person is usually a full sibling, which isn't always an option. And then enters gene therapy.
Got it. And of course, an identical twin wouldn't do you any good because that twin would also have sickle cell disease.
Yes, likely so. Yep, exactly.
So tell us about gene therapy, which has been talked about a lot over the last year or two.
Yeah, it's a very exciting time, a new time, a time of still so much discovery. But another time I can say being nerdy is cool. Science is fun because, we're able to mitigate that challenge of not having a good match by allowing a person to be their own match for a curative option. And so there are 2 main ways in which we do that now. One of those is through a technology called CRISPR-Cas9, where a certain spot in our genetic code can be identified and then removed. In that instance, the goal of that intervention and therapy is to take away that gene that tells us when we're kids to stop making fetal hemoglobin, like we talked about earlier. So then your fetal hemoglobin starts to ramp up and your percent of sickled cells are decreasing, thus offering a cure.
And in that setting, how much fetal hemoglobin do you wind up with?
So it can even be as much as half of your cells making fetal hemoglobin, thus making you more like a trait status, like we talked about earlier, where the symptoms aren't as obvious, that doesn't affect your organs, the quality of life is totally.
And half is enough.
It is ideally more, but half is enough to take you to trait status. Yep.
Wow. So you said there were 2 ways of doing this, I think.
Yes. The second way is through something we call using a viral vector, or using the intelligence of viruses and viral infections to introduce new genetic code into our stem cells, or the parent cells of our red blood cells. Actually, that method has been around longer than the CRISPR-Cas9 technology. And what that does is it actually creates non-sickling hemoglobin. So rather than saying, hey, I want to increase hemoglobin F and really get that going, this one says, actually, I want you to make new hemoglobin that doesn't sickle at all. And again, the goal is to have a robust amount of that new hemoglobin around, such that sickle cells are not impacting the person's organs, clinical manifestations, and or quality of life.
And when was the first time gene therapy was given for sickle cell disease?
Do you mean in an FDA-approved setting or in a research setting?
In a, let's say, a research setting even.
Oh, okay. So it's been years, actually. I mean, there's a great group at the NIH led by John Tisdale and Courtney Fitzhugh, who are really amazing transplanters who have done the preliminary work for this, has been doing this for many, many years. It was FDA approved in December of last year. So,
wow.
Yeah, so it's still very, very new, and we're still learning so much.
And what are the complications of gene therapy?
Yeah, so, we didn't talk in detail about the bone marrow transplant process, but it mirrors very much the gene therapy process. First, we have to pick the right candidate. Who is a person whose organs are healthy enough to be able to go on this journey, who has the psychosocial support that they need to go on this journey, who has proximity and to a treatment center that can do this safely, right? Once that's established, then, we in the gene therapy process, you have to harvest someone's stem cells. And so you can do that through a process called apheresis, which we use in sickle cell to replace abnormal red blood cells with normal ones. But that may require several rounds of that procedure. And while those stem cells are off being processed and made new and whole, the person we have to keep them healthy, right? We got to continue to make sure their sickle cell isn't having a deleterious effect on their body. And when it's time to receive those cells, this is when it really, really mirrors bone marrow transplant. So the person has to come into the hospital. They get chemotherapy, which helps their body recognize, make room for those cells and make sure that their body doesn't attack these new cells. That means during this time, their immune system is nearly zero, right? Because this chemotherapy is not just taking out the red blood cells, it's taking out our white blood cells that help us fight infection and our platelets that helps prevent bleeding acutely. And so we become their immune system. We become their platelets. And so they have to stick with us during that. The type of chemotherapy that they get can have impacts on fertility and other organ functions. And then eventually, after some time, then those cells begin to grow on their own, those new stem cells. And so we take, this is a journey, certainly, and the risks are high, but the reward is also quite high.
But not necessarily for the faint of heart.
Oh, no, absolutely not. And, we think about how we deliver gene therapy and keeping the patient safe. But one of the things that I think is a hallmark of a good sickle cell center is caring for the whole patient and, not just when they're with us, but also ensuring the goal is for them not to just survive, but to really thrive. And that means, how is their life affected by the treatments that are going to cure them? How are their families affected, their children, really keeping them whole. So.
Wow. Well, I'm sure that in the years ahead, we will somehow figure out ways of delivering this therapy and having it be more tolerable. And in the meantime, there'll be some people who are choosing to do this.
Yes, yes, certainly. I think there are more than just a few people who are choosing to do this because of life with sickle cell disease. That risk becomes worth it. So,
yeah. So I want to end on a somewhat different note. And as challenging and horrific as it can be to have to deal with the pain of sickle cell disease and everything with it, I think that one of the, in many ways, equally painful parts is that I think for many years, sickle cell being largely a disease in the U.S. that arose in people who are Black was a disease that I think people very often didn't get the kind of treatment that they should have. And I remember being a young doctor, and I will just share that the way people talked about patients with sickle cell disease wasn't okay. And just like you to reflect a little bit on the disparities patients with sickle cell disease face and how much of that is due to just the fundamental racism that exists in our society.
Absolutely. So, we know that how we deliver care and our capacity as providers and ultimately health outcomes are driven by larger things. So we know that as prejudice and racism infuses into our institutions, those affect our policies. Those policies affect our environments, right? Whether it is a living environment, funding environments for research and innovation. And those things affect ultimately diagnosis, treatment, and then really mortality. It's not even in just sickle cell disease. We know that that is across the board. I think most notably, most recently, we saw that during the COVID pandemic. And then also when we look at data around Black infant and maternal mortality.
Absolutely.
And the stigma with sickle cell disease mirrors the stigma of being an African American in the U.S. health system, and then also having a disease that has pain, which is treated by opioids, right? So there's this other layer. We see that come up in funding, again, which for us drives a lot of innovation, like gene therapy. We see the funding disparities between other diseases, like people like to compare to CF a lot, which is another rare disease. We see that in provider.
CF meaning cystic fibrosis.
Yes, cystic fibrosis. I'm so sorry. Yes, cystic fibrosis. We see that in provider attitudes, like in training, like what you just mentioned, and kind of like working on that stigma. We see that in how society views persons with sickle cell disease as well. And it's a very salient and current issue. I think what we are doing now, acknowledging that this exists, and then thinking about, in the scope of our own power, how do we change that? So is it educating our peers? Is it making the right decision for the right patient at the right time? Is it creating space and acknowledging the historical disparities and inequities that have led to this point? There's so many ways to address this issue that continues to remain pervasive in our industry.
Dr. Cece Calhoun is an assistant professor of medicine and hematology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.